Myasthenia gravis is a chronic autoimmune neuromuscular disorder that leads to weakness in the skeletal muscle, and it occurs when the body's immune system produces antibodies that block or destroy the communication between nerve and muscles at the neuromuscular junction. So here is the neuromuscular junction, and previously we have seen what is the normal physiology of a neuromuscular junction. So in this video we will see what is the dysfunction that occurs that may lead to myasthenia gravis. So our body's immune cells that produce some autoantibodies by default, and that autoantibodies are basically IgG types. These are the autoantibodies, and basically these autoantibodies are IgG types. Okay. Now what happens? These autoantibodies mimic the expression of acetylcholine, and they binds with acetylcholine receptors. So these antibodies are named as anti acetylcholine receptor antibody. For 85% of cases of myasthenia gravis, the antibody is produced the type of anti-acetylcholine receptor antibody. Okay, and they are basically IgG type of antibody. So these autoantibody can replace the acetylcholine receptor in the synaptic cleft. We already know that this is the synaptic cleft. These are the acetylcholine receptors. These are the ACH receptor that are present on the surface of a skeletal muscle. So these autoantibodies come and they join with these receptors. You can see that can bind with two one antibody can bind with two acetylcholine receptor molecule, right? Because this IgG type of antibody is a divalent antibody. It has two antigen binding site. Actually antigen is a foreign pathogen, but the defect is that our body cannot recognize our own cells. They thought the our own muscle cell is the antigen, so there is a binding of antigen antibody complex, and that causes that acetylcholine receptor cannot bind with these acetylcholine molecules. These are the acetylcholine molecules, so it cannot bind with acetylcholine molecule, and acetylcholine receptor cannot get open. Anti acetylcholine receptor antibody binds with acetylcholine receptor, and that may lead to no influx of Na plus sodium ion into the skeletal muscle, and there is no EPP. So there is no action potential in the muscle, and there is no calcium release from the sarcoplasmic reticulum to the muscle, and no skeletal muscle contraction. But this is not the ultimate cause, because there is another reason, that anti-acetylcholine receptor antibody, it activates a complement cascade. Complement cascade. Cascade means a chain of events, and they may lead to formation of membrane attack complex. Okay, membrane attack complex. So by its name, you can guess its function, that it will affect the membrane. Which membrane? In that case, it will affect the postsynaptic membrane where the acetylcholine molecules are attached. Okay. So what it will lead to? It will lead to the damage to the membrane. Okay. Damage to the membrane. Damage to the membrane. Then it will reduce in the number of functional acetylcholine receptor, reduce in the number of functional acetylcholine receptors, and destruction of folds in the postsynaptic membrane. Destruction destruction of folds in the postsynaptic membrane. Actually, it's a part of immunology, that how this complement cascade get activated by the antibody, because only antibody IgG and IgM, this type of antibody only can activate this complement pathway. And for this disease myasthenia gravis, the antibody is IgG type, so it can activate this complement cascade. There is activation of some protein, like that is they are denoted by C1, C4, like this way. So firstly, C1 get attached with the Fc region of an antibody. So if it is a structure of an antibody, you have to know about the structure of antibody, but later maybe some in some other classes I will describe some part of immunology. But for now, just remember that it's a part of Fc region. It's a Fc region is the part of an antibody, and in this part, that C1 protein get attached, that is a complement protein, and then they will activate its another companion, like C4, C1, again C4, then C4 activate C2, then C2 activate C3b, and so on, like C5b, and ultimately C5b get attached with C6, C7, C8 and C9. So they form a complex like this way, and these complex get attached with the postsynaptic membrane, this whole complex. Okay, they sit on the skeletal postsynaptic membrane of their postsynaptic membrane of the skeletal muscle, and they create a big hole within the muscle and disrupt the structure of postsynaptic membrane, where the acetylcholine receptor no longer attached, and definitely they damage the membrane. They reduce the number of functional acetylcholine receptor, and destruction the folds of these folds of the muscle membrane. Okay, and that will lead to myasthenia gravis for 85% of cases. Another 15% case is different, and I will describe it. Okay, in myasthenia gravis, besides the more common anti-acetylcholine receptor antibody, that is a cholinergic receptor antibody, because acetylcholine, okay, so it means nothing but the AChR, anti-cholinergic receptor antibody also produce these two antibody, like anti-mask antibody and anti-LRP4 antibody. Okay, so another two antibody, and this case is like for 15%, we can see that they produce anti-mask antibody and anti-LRP4 antibody. So what are they? Anti-mask means, firstly you have to know this, what is mask. Mask means that the muscle, mask means muscle specific kinase, muscle specific kinase. And this muscle specific kinase mainly function in clustering and maintenance of acetylcholine receptors in the postsynaptic membrane. So in the postsynaptic membrane, acetylcholine receptors are clustered and they fixed at that place because of this mask protein. Okay, and also there are another protein, that is low density lipoprotein 4, that is low density lipoprotein 4, which is also produce stability, receptor stability and receptor function. They help in the trafficking of the acetylcholine molecule through the acetylcholine receptor. So what happens when we produce antibodies against these two molecule like mask and LRP4? These antibody destroy these mask and destroy the LRP4 functions. Because they are anti-mask antibody, they will function against the mask protein and LRP4 protein, and they will hamper the acetylcholine receptor molecule stability. They will hamper the neuromuscular junction. Okay, and they play a crucial role in disrupting the clustering of maintenance of acetylcholine receptor. That's why leading to a reduction in the number of functional acetylcholine receptor on the muscle surface. Okay, myasthenia gravis is a chronic autoimmune disorder that causes weakness in the skeletal muscles due to impaired communication between nerves and muscles. So, here are the common signs and symptoms that include, firstly, the ptosis. Ptosis means drooping eyelids. We can see this is a proper eyelid and this eye is drooping. Okay, so this person is cannot able to open her eye properly because of the muscle weakness caused in the eyelid muscles. That's why. Okay, so it is known as ptosis. Ptosis. Okay, so drooping of one or both eye. Next is the diplopia. Diplopia means double vision. A person see the object like there is a overlap of the object and getting hazy and double. So that is why this is a difficulty in visualizing an object, and this is occurs due to muscle weakness or extraocular muscle weakness. Extraocular muscle weakness. So first one is ptosis, drooping eyelids, second one is diplopia, and third one is dysphagia. Third one is dysphagia, it's trouble swallowing. It's trouble swallowing. It's trouble swallowing. That means leading to choking or difficulty eating. It specifically affects the throat muscles. Okay, so a person face difficulty in eating and leading to choking. Next, the weakness in facial muscles that causing a drooping appearance or difficulty smiling. Here a person cannot smile properly because his or her appearance gets changed and it's drooping because of facial muscle weakness. Okay, cannot smile properly, and it is this ptosis. Okay, and this person is affected by myasthenia gravis. And also neck and limb muscle weakness, that is the weakness in neck muscles causing head droop, and weakness in arms and legs making it difficult to lift objects or climb stairs. For severe cases, there is a case that known as myasthenia crisis. Myasthenia crisis. For this, it causes breathing difficulty. Okay, and it's a medical emergency, difficulty in breathing. Okay, and it's very very severe case. These are the symptoms. Like first one is muscle weakness. First one is muscle weakness. And the second is the eye related symptoms, that is ocular myasthenia. Third one is facial and throat muscle weakness. Facial and throat muscle weakness. Fourth is neck and limb weakness. Neck and limb weakness. And fifth is the respiratory muscle weakness. Respiratory muscle weakness means severe case, and it's myasthenia crisis. Myasthenia crisis. So these are the symptoms, sign and symptoms of myasthenia gravis. And next, the diagnosis. Okay, the diagnosis of myasthenia gravis (MG) involves a combination of clinical evaluation, laboratory tests, and imagining. Okay, so here's an overview of the diagnostic process. Firstly, it's clinical evaluation. And clinical evaluation for the symptoms: muscle weakness that worsens with the activity and improves with rest. Commonly affected muscles include eye muscles, that we have previously seen in the sign and symptoms, that a person's eye muscles get affected, that causing drooping eyelids or double vision. His or her face, throat, and neck muscles get affected, and that causing difficulty in swallowing, speaking, or holding up the head. Limb muscles, especially the proximal muscles, get affected. Okay, so for physical examination, the test performed like fatigability, such as sustained upward gaze. If you ask that person to look upward for a time being, he cannot, because their eye muscles get affected, extraocular muscle get affected, as well as eyelid muscles get affected. And if you ask them for repeated arm movements, it very soon they achieve the fatigability. Okay, and that is the physical examination performed for diagnosis of the myasthenia gravis. Okay, basically it's fatigability test. Fatigu fatigability fatigability test of the muscles. And last thing, and the thing is like antibody testing. For We can test their anti acetylcholine receptor antibodies for 85% cases. And then we found 80 to 90% of cases generalized myasthenia gravis, they have developed anti acetylcholine receptor antibodies. Anti acetylcholine receptor anti acetylcholine receptor antibody they have developed for 80% cases MG, myasthenia gravis. And low density lipoprotein low density lipoprotein receptor related protein 4, LRP4 also. This is a antibodies may be tested in rare cases if another antibody tests are negative. And for mask, it's muscle specific antibody, muscle specific kinase antibodies. It's seen for 30 to 50% patients with acetylcholine receptor negative antibody. Okay, so if this test get negative, then we test for anti-mask antibody. If this anti-mask antibody test get negative, then we test LRP4. Okay, and there is another thing, that is electrophysiological studies. In electrophysiological studies, we test repetitive nerve stimulation, that is caused by we test a specific nerve which is stimulate a specific nerve means a motor neuron which is specific for a muscle, and we stimulate it repeatedly, and we diagnose that it get fatigue soon. Okay, so this test is very important because there is a mild difference with the other abnormality, that is Lambert Eaton syndrome. This is another disease. I am not going to discuss it here, but it also correlate with myasthenia gravis. So repetitive nerve stimulation is a very good diagnosis for myasthenia gravis. For myasthenia gravis. And then another test, that is the endophonium test. Endophonium test means in this test what we do, firstly we administer a drug that is known as endophonium chloride. Endophonium chloride. Basically this chloride is an anti it's an anti acetylcholine anti acetylcholine esterase anti acetylcholine esterase drug. That endophonium chloride is basically anti-acetylcholine esterase drug. You remember what is the function of acetylcholine esterase? Acetylcholine esterase enzyme helps in the removal of acetylcholine molecule from the synaptic cleft after its binding with the acetylcholine receptor in the postsynaptic membrane. That means after muscle contraction it helps in muscle relaxation for normal muscle contraction. But when there is a problem, when for myasthenia gravis patient, we already know that number of acetylcholine receptor molecule is very rare, very less in the postsynaptic membrane. So what we do, we remove this anti-acetylcholine esterase enzyme by the help of anti-acetylcholine esterase drug that come and dysfunction the acetylcholine esterase, so that it cannot remove this acetylcholine molecule from the synaptic cleft. Okay, so this is the medication that we can do, but it's very rarely used. Okay, and then the another thing is imaging studies that are CT scan or MRI to identify thymoma, and this is a very important point. What we can diagnose by imaging studies, and imaging studies is a chest CT or MRI. It's a chest CT or MRI. Okay, to detect thymoma. Thymoma, we will come to this point after this pulmonary function test. We also assess respiratory muscle strength by this pulmonary function test. We assess respiratory muscle respiratory muscle strength, especially in cases where respiratory muscle is muscle respiratory involvement is suspected. Okay, and why it's thymoma? Because for myasthenia gravis, uh, for myasthenia gravis patient is noticed with thymic abnormality. If you remember that there is two kind of myasthenia gravis patient, we have previously discussed that there are two type of antibody, like anticholinergic receptor antibody AChR, and for mask and LRP4. So I will discuss it here also, that myasthenia gravis MG, it is developed in two cases, for anti acetylcholine receptor antibody and anti mask antibody and anti LRP4 antibody, right? But for anti-acetylcholine receptor antibody, it affects the thymus. For this, we can see this thymic patient with thymic abnormality abnormality but we do not see this thymic abnormality in case of anti-mask or anti-LRP 4 mediated antibody. Okay, so we cannot do this thymectomy in case of these two cases. Only we perform thymectomy for anti-acetylcholine receptor antibody mediated myasthenia gravis. Is it clear? Okay, so thymic abnormality is also seen within two kind of people, like for 50% cases is thymic hyperplasia, thymic thymic hyperplasia, thymic hyperplasia. And for thymic hyperplasia, we only see that the thymic abnormality, and it cause for the younger female. Okay, and another 10% people might be affected by tumor. They develop tumor, so it is the thymoma, and it's seen in older age people. Okay, so this is the diagnosis part of the myasthenia gravis. And for myasthenia gravis, we what are the type of medication we should use? Medication, firstly, we can use acetylcholinesterase inhibitors that we have previously said. Acetyl acetylcholinesterase inhibitors. Acetylcholinesterase inhibitors, named as neostigmin. This is specifically neostig neostigmin, or um, pyridostigmin. Pyridostigmin. These two drug we can use. Next treatment is corticosteroids. Corticosteroids. Corticosteroids used for immunosuppressant, that is previously, that is suppress the auto antibody production. Okay, it's cause the immunosuppressant, which is very important. And then we do plasmapheresis or intravenous immunoglobulin. Plasmapheresis or intravenous immunoglobulins, or intravenous immuno intravenous immunoglobulin And the last thing is thymectomy. And this thymectomy we only do perform against the myasthenia gravis formed by the anti acetylcholine receptor antibody mediated myasthenia gravis. We do thymectomy only for these patients. Okay, so hope you understand myasthenia gravis well. If you have, if you still have any kind of confusion or anything that you want to know in detail, please write in the comment section. And if you like my videos, then also like my video and do comment and stay tuned with me. So see you again in the next class.